Okay, welcome to Endocrine Pharmacology, diabetes, thyroid disorders, bladder disorders, and erectile dysfunction. So what I want to do is I'll go over some of the hormonal issues first, so diabetes and thyroid and sex hormones. Then we'll talk about the bladder disorders and ED. So we'll start with diabetes mellitus, or the pathology. There's type 1, which the pancreas doesn't produce insulin. It's usually diagnosed in childhood and treatment requires insulin. Type 2, the insulin's produced but not utilized very efficiently, and traditionally diagnosed in adulthood, and we're seeing it in children now, obviously with the American diet, and then treatment starts with oral medications. Gestational diabetes, insulin's produced but not utilized very efficiently, and occurs during pregnancy and continues shortly after delivery. It's treated like type 2 diabetes with some caveats. All forms of diabetes result in excess glucose in the blood, and the medications all focus on moving glucose out of the blood and into cells or out of the body. The pathology of diabetes mellitus. So multiple organs are involved in regulating insulin and glucose levels. The liver, the pancreas, the small intestine, and the circulatory system. Glucose is ingested with food. It comes through the stomach into the small intestine where it's absorbed. From the small intestine, it goes into the bloodstream. That's a donut. The organs become targets, and one, we can stop the intestinal absorption of glucose. 2, we can stop the liver from making glucose. 3, we can increase insulin sensitivity. 4, we can increase pancreatic insulin production. And 5, we can just provide insulin. So in the pancreatic beta cells, the red cells are in the isolate, and it's called an isolate of Langerhans because it looks a little bit like an island. Those are the beta cells. They're responsible for insulin production and release, and eventually stop producing insulin. This is problematic in diabetic patients. One of the oral medications we can use for diabetes are the biguanides, or metformin, which is brand glucophage. It works on 3 of the targets. 1, stops intestinal absorption of glucose. 2, stops the liver from making glucose. And 3, increases insulin sensitivity. Indications are type 2 diabetes, gestational diabetes, and the adverse drug reactions include nausea and vomiting, diarrhea and loose stools, and lactic acidosis, which is pretty rare. The diarrhea and loose stools can depend on how quickly someone has started someone on metformin, and it's unfortunate because a lot of times this is a very good medication, but when started too quickly, the patient will say, I don't want to take that stuff, give me something else, when if they had started at a lower dose, it might have been okay. The most common reason patients stop taking it is the diarrhea. 53% of patients experience it, and it must be taken with meals. So start with a low dose and gradually increase. 2 oral medications for diabetes mellitus, the sulfonylureas. We don't use them as much anymore because of the hypoglycemia, which I'll talk about in a minute. But glyburide, brand Diabeta, and glipizide, brand Glucotrol. These work on one of the targets. So 1, increase pancreatic insulin production. The beta cells create insulin. So indications again, type 2 diabetes, and really for gestational diabetes, this would be last line. Adverse drug reactions, this is a real concern that we don't really have with glucophage, and that's that we can have hypoglycemia and nausea and vomiting. The hypoglycemia is a serious problem, and it must be taken with a meal to be prevented. Use it for a limited time, for years. The beta cells can only produce insulin for so long before they're done. Another oral medication for diabetes are the DPP-4 inhibitors, sitagliptin, brand Januvia. So dipeptidyl peptidase 4 inhibitors. They work on one of the targets, and that target is the increased pancreatic insulin production. So again, the indication would be type 2 diabetes, and adverse drug reactions, we don't really see too many, but pancreatitis is rare. Injectable meds for diabetes, the insulin. So insulin is the hormone that causes glucose to be taken up by the cells. And there's several different types of insulins. The difference is how long they work for. So when we're talking about when we're talking about the injectable meds for diabetes mellitus include insulins. So insulin is a hormone that causes glucose to be taken up by the cells. There's several different types of insulin, and difference is how long they work for. So 2 types are available over the counter. The others are prescription only. And the indications: type 1 diabetes, type 2 diabetes, and gestational diabetes. The adverse drug reactions, of course, hypoglycemia, that we reduce the glucose too much. Any form of insulin produces the highest risk of hypoglycemia, so even the highest dose of sulfonylurea doesn't come close to the risk of insulin. So this is a real concern. One image that you want to kind of put in your brain is this one of how high the spike goes over the time. So something that's very rapid acting, you see that it has a very high spike. And then something short acting like regular, its spike is a little lower, intermediate, even lower than that, and then long-acting glargine works over about a day. And we'll go through each of these, but again, this is something you want to kind of get in your brain, that as I go longer, I'm going to have much lower effects overall. So the insulin Lyse Pro, or brand Humalog, it works within like 15 minutes. With meals, we use it 30 minutes before eating, and it lasts for about 2 hours. Regular insulin works with 30 minutes. Within 30 minutes, we use about an hour before eating, and it lasts for about 4 hours. Now, I say it's over the counter, but that doesn't mean that you're going to find it in the refrigerator next to the soda. It's simply that you don't need a prescription. You can go to the pharmacy and just say, hey, I'd like to buy insulin, and it's possible to buy it, although the cost is so prohibitive, most use their insurance for it. The other over-the-counter one is NPH insulin, or Humulin N. The P in NPH is for protamine. It comes from trout. And it works within 4 hours, and it covers between meals and overnight, so it lasts 8 to 12 hours. And finally, there's the long-acting insulin glargine, Lantus, Basaglar, and Toujeo. Lantus, one way to remember it is it lasts all night. It's very long-acting, and it's used nightly to provide 24-hour insulin delivery. So that's a very, very abbreviated review of insulin, oral and injectables. Thyroid disorder agents. So we begin with the thyroid. It's a butterfly-shaped organ on the trachea, and a healthy thyroid has a perfect balance of hormone levels. Not too low, not too high. If we get hypothyroidism, we go too low, then we have fatigue, weight gain, cold all the time, very shaky. If, on the other hand, we're way too high, it's the opposite, where we can't sleep rather than fatigue. We have weight loss rather than weight gain. We have sweating rather than being cold all the time, and very jittery, very bouncy. So that's what happens when it goes too high. So hypothyroidism is the most straightforward. We replace it with hormone levothyroxine and Synthroid, which is literally squishing the words synthetic and thyroid together. The dose is modified based on the symptoms and the hormone levels, and it takes about 6 to 8 weeks to see the full effects. The indication, of course, hypothyroidism, and the adverse drug reaction is kind of related to the thyroid levels. So we kind of look at the symptoms, but what we're really worried about is going too far, where we take someone hypothyroid and make them hyperthyroid. When we look at the dosing, a small dose makes a big change. So it's dosed in micrograms rather than milligrams. And just the conversion, just remember that we have 1,000-fold difference between a microgram and a milligram. So we take with water first thing in the morning with nothing else is the best way to do it. And we want all the dose to be absorbed consistently due to the potency of the hormone. An antithyroid agent could be something like propylthiouracil. It stops the production of new thyroid hormones. And the dose is modified based on symptoms and hormone levels. So it takes 6 to 8 weeks to see full effects. Indication is hyperthyroidism. Adverse drug reactions are related to thyroid levels. Again, see the hyperthyroidism symptoms. Sex hormones and contraceptives. So testosterone, it comes as androgel or a transdermal gel. It's synthetically made, but it's identical to endogenous testosterone. The application area should be covered to prevent transfer to children. So we want to be very careful when there are children around. Indications, low testosterone levels, obviously, and then the adverse drug reactions, those things that you might expect, acne, prostate enlargement, and gynecomastia, which is relatively rare. Testosterone is available in a variety of dosage forms: creams, gels, patches, injections, and implants. And the hormone alone can be used for low testosterone levels in men and women, female to male gender conversion, many different uses. Hormonal contraceptives, the cycle overview, looking at estrogen and progestin levels and how it goes from the follicular phase to the ovulatory phase to the luteal phase, and then the egg releases from the ovary on day 14. So as we look at the mechanism of action and kind of put this picture in our heads, all the hormonal contraceptives, they prevent ovulation. The egg never gets released. They thicken the cervical mucus so sperm can't reach the egg. All form contain progestins, and some contain estrogens, but we don't see estrogen-only contraceptives. Now, the pregnancy rates on oral contraceptives should be around 0.5%, but we're humans. The way that we actually take it, it's closer to 8%. But the theoretical number would require perfect adherence, taking it every day, exact same time. One of the drugs, this combination, is norethindrone, which is a progestin, with ethinyl estradiol, which is an estrogen, with ferrous fumarate, which is iron replacement, and this is loestrin 24-FE. Same hormone amounts in active pills for 24 to 28 days to reduce the length of menstruation. But we also have these iron pills at the end. We have a combined oral contraceptive, so norgestimate, which is progestin, and again that gest stem, and then the ethinyl estradiol for estrogen. It's all in Trisprintec, and there are 3 different hormone amounts over 21 days, each 7 days long. So more estrogen at the beginning, more progestin at the end. Last week is placebo. Okay. So why do we do this? We're just really mirroring the normal cycle. Another more recent, not relatively recent, combination is norelgestromin with an ethinyl estradiol in a transdermal patch. So it's applied to the torso, the back, or the buttock once per week for 3 weeks, then a week off. So very similar to the dosing for the tablets, except only need 1 patch. So it stays on all week long, even when showering or bathing, and the actual failure rate closer to around 8%. Same thing with the vaginal ring, so etinogestrel, ethinyl estradiol vaginal ring or NuvaRing. Progestin is etinogestrel, estrogen is ethinyl estradiol. It's this flexible polymer ring that releases hormones slowly, and it's inserted vaginally for 21 days, removed for 7, then a new one's inserted. Actual failure rate again around 8%. Emergency hormonal contraception, so we're talking about levonorgestrel oral tablet or the Plan B 1-step. It's a progestin, and it's a progestin-only contraceptive, and it's effective up to 72 hours after unprotected sex, but you really, the closer you get to when it happened, the better off you are. It doesn't terminate a pregnancy. It simply is meant to prevent it. The odds of pregnancy with no contraception are normally 8%. The Plan B is 89% effective, so the odds of pregnancy with Plan B go down to 1%. But it comes at the cost of extreme cramping and discomfort. One thing that can be done is to take some soda, let it go flat, and sip on it. It can help with the nausea. Contraceptives, IUDs, so copper intrauterine devices. Copper T380A is Paragard, so no hormones. Copper is spermicidal in itself. Lots of cramping. It's uncomfortable at first. The actual failure rate is around 0.8%, and it's inserted once every 10 years. There's a hormonal intrauterine device, IUD, and this releases a very small amount of progestin. There's less cramping with the copper IUD, and then the actual failure rate at 0.2%. So inserted once every 5 years. Going on to some of the bladder disorders. So overactive bladder, the pathology. There's a disconnect between the nerves, the bladder muscle, and the brain about the urine quantity. There's a sudden urge to empty the bladder even when it's not full. And it's most commonly seen in older adults, but it can occur anytime with male, female. And the medications focus on drying things up. So the antimuscarinics, or anticholinergics, however you want to call them. Oxybutynin, brand Oxytrol and Ditropan. Solifenacin, which is Vesicare. Tolterodine, which is Detrol. They relax the smooth muscle of the bladder, the detrusor muscle, allowing more urine to fill in the bladder before needing to be emptied. Indications, obviously OAB, which is overactive bladder, and then adverse drug reactions come from the anticholinergic effects, drowsiness, confusion, dry mouth, and urinary retention. The next issue we'll talk about is that urinary retention, which is inability to avoid the bladder content. It's caused by poor detrusor muscle contractility, so the contraction is voiding of the bladder, inappropriate bladder relaxation, and the medications focus on rewetting. So cholinergic muscarinic are the opposite of anticholinergic, so these would be ones that take care of that retention. The one example we could use is bethanechol, or uricoline. It increases the muscle tone and contractility of the detrusor muscle, allowing for bladder voiding. The indications are urinary retention. Adverse drug reactions, so you can have excessive tear production, loose stools, diarrhea, cramping, urge to urinate. All of these things are cholinergic effects. BPH, a little bit different. So the growth of the prostate that squeezes onto the urethra inhibits urine flow. The urge to urinate is still there, but the flow is blocked. So there's two treatment pathways. We can, one, increase the diameter of the urethra, or two, shrink the prostate. So a normal prostate is a bit larger, and then benign prostatic hyperplasia, we see that we have an expansion of the prostate, and it puts this pressure on the urethra. The first group that we could use are the alpha-1 blockers, so tamsulosin, which is brand Flomax, alfuzosin, which is uroxetrol. It causes a relaxation of the prostate, increasing urine flow, increases the urethral diameter. Indications, obviously, BPH, benign prostatic hyperplasia. Adverse drug reactions, they're all uncommon: dizziness, headache, or the static hypotension. The 5 alpha reductase inhibitors, dutasteride, finasteride, they decrease hormone production, and the prostate uses to grow. Eventually, this leads to prostate shrinkage, and the indications, BPH again, and the average drug reactions, decreased libido and erectile dysfunction. Talking about that next topic, ED, so this is the inability to attain or maintain an erection. Most men with ED have some underlying microvascular disorder, whether it be hypertension, coronary artery disease, peripheral artery disease, or diabetes mellitus type 1 or 2. Treatment involves increasing blood flow to the penis, and we use the phosphodiesterase 5, PDE5 inhibitors. So sildenafil, brand Viagra, taken 1 hour before needed. Tadalafil, Cialis, taken 1 hour before needed, lasts 72 hours. So it increases penile blood flow through the nitric oxide-induced vasodilation, and the indications, of course, ED. Adverse drug reactions you would expect with something that is like a nitrate, so headache, flushing, hypotension. We do want to be careful, though. We don't want to use these PDE5 inhibitors with nitrates, so they must not be used with them. Nitroglycerin tablets, patches, gels, isosorbide mononitrate, dinitrate. Okay, the combination can cause extreme vasodilation and hypotension.